It's so great to be able to sit down with you now after all of the treatment. You were my coach from beginning to end. And when I first came to you and we realized it was triple negative, you introduced to me many new words that I'd never heard before. I'd never heard triple negative before. But neoadjuvant, this is a phrase that we're going to be hearing a lot more as we go forward. Why don't you just simply tell us what that means?
When we think about treatment for breast cancer, we know there are many modalities that have to be part of the whole program. There's surgery, there's often some kind of medical treatment. It could be chemotherapy, hormonal therapy, biologic therapy, radiation treatments are used. How do we put that all together? How do we sequence those treatments? And in some instances, we've learned that it might be best to start with medical treatment, not surgery first. And when we do the medical treatment first, chemotherapy or even hormonal therapy, we call that neoadjuvant therapy. The neo means it's pushing it up front.
What is the advantage of doing the chemotherapy or whatever the therapy is first before surgery?
There are several advantages to doing the neoadjuvant therapy, the treatment before surgery. Originally, this was designed so that we could shrink tumors and hopefully prevent women from having mastectomies, because initially, if a tumor was big, the surgery had to be a mastectomy. So the idea was we could convert over to breast-conserving therapy or lumpectomy. But what we realized along the way was this gave us a living model to see how well the treatment was working. So we could start the treatment and then monitor the clinical progress, actually seeing the tumor shrink and measuring it or re-imaging if we had to. And then even if we have to make adjustments along the way to make sure that we're really getting rid of those cancer cells.
So, because in my case, that really worked out because I had a much smaller surgery.
Oh, absolutely.
But I had a lot of women write me on social media and say, why wouldn't you have just done a mastectomy and get those breasts off of you and get the cancer out of your life? That's a hysteria that's very real out there right now.
It is. And you know, Joan, it took us decades for women to not always have mastectomies. 20 years ago, 30 years ago, if a woman had a lump in her breast, automatically it was a mastectomy. And we had to do the science, we had to do the clinical trials, and it was actually thanks, believe it or not, to the women's movement in the 1970s that pushed forward the physicians to say, wait a minute, there is another way. We can do a lumpectomy and radiation, and now we have 30, 40-year follow-up, even presented this morning at the meeting that we're at this weekend, confirming that in the appropriate cases, a lumpectomy followed by radiation therapy is absolutely equivalent in terms of survival and cure to doing a mastectomy.
I had a woman just write me the other day that said, I have a tumor in one breast, and I'm being recommended by my doctors to have a double mastectomy, and I get 2 new boobies, and they'll be perfect, but I just think I can just have a lumpectomy. So I think even from the doctor side of it, forget women's hysteria, there is that tendency to just push that through.
Yeah. I think part of it is that there are some women, even with small tumors, for whom mastectomy is the right treatment. That's a very small subset of patients. People at very, very high risk for developing another breast cancer. So in that case, doing the mastectomy maybe is preventive treatment. That's a very small number of women. Part of it is also driven by the fact that our plastic surgery has gotten way better. So we can do reconstructive surgery that leaves women looking cosmetically, really good. And I think sometimes that pushes the decision a little bit.
It's almost impractical to expect that, when you get to the doctor, that they can outline every single thing that is available to a woman.
Right. Well, hopefully what we can do is focus in on the things that are relevant to each individual person. And we want to try as much as possible to personalize that medical treatment. And we've been hearing that over and over again in really every area of medicine, but particularly in cancer treatments, to individualize the treatment decisions and to use the right tools for each woman.
starting with, of course, the screening process, because we
Yeah.
know how important it is to catch this early.
Yes. Yes.
Starting with mammograms.
Yes.
I mean, it's so confusing. Women actually open a magazine today and see an article that says, should I say no to a mammo? And they are left in a real conundrum.
Yeah. It's very, very confusing because we see all these different guidelines coming out now. And I think that we have to be very clear that it is important to try and find breast cancer at an early stage. And it is true that one size fits all may not be the best way to go about screening, but we have to start somewhere. And there has to be a clear message that everyone needs screening. Examining your own breast, being aware of a new lump or a change in the way the skin appears, or if the nipple becomes retracted, that should be a warning sign. Gee, I better check that out and go to my doctor. And to start screening with imaging. The mammogram is still the gold standard general screening test. We start there. And then we may have to add other things, ultrasound or MRI or some of the newer modalities for imaging, but we have to start with basics.
How important is it, thinking of the doctors, the doctors that you will work with if you should get breast cancer, how important is the conversation amongst all your different doctors? Because I know in my case, of course, I had treatment in 3 different states.
Yeah,
and
right.
you all kept in touch with each other.
Right.
And studies do show that you'll get your highest rate for success if all the doctors involved in your treatment have a good working relationship.
It has to be a team. It really has to be a team. And ironically, the patient is the captain of that team. And all the rest of us have to kind of get in line and say, okay, what are we doing to make sure that we have the right, set of plays for this particular individual?
That's scary for a woman, though, to think she's going to be the captain of that team. I mean, this is coming at a time when you're practically paralyzed by those 3 little words, you have cancer.
Well, you're not going to be making all the medical scientific decisions, but it's going to be based on what your individual needs are. And then the rest of us have to communicate with one another, come up with a unified plan that makes sense. But as you well know, tweak it along the way, because you can map it out, but you have to kind of adjust things as they go. And fortunately, you put together a fantastic team, and we were all able to work together very well.
And also going along the way, we had some decisions to make here and there. And I kind of decided there were no shortcuts in cancer care.
Those were tough decisions, but made, I think, based on information, a lot of thinking things through, and also knowing that you had the support of the other part of your team, not just your medical team, but everyone at home, everyone in your intimate circle, your husband, your kids, and your colleagues, and your close friends, and now this enormous community that you have embraced by stepping out so publicly through this journey. It's really quite extraordinary, Joan.
Well, part of the reason why I embrace it too, though, is that I've heard from so many women out there who don't have the kind of support system that I do. And it's a very long and lonely and tough journey for them. Part of the kind of decision process that we went through, just how much chemotherapy would we really put me through? One of the shifts in focus might have to be, do we just treat the cancer and go after the cancer, or do we have to worry about the woman who's going to live hopefully long after, and the side effects that can come from chemotherapy?
Yeah, you're getting at a really important issue, which is, yes, we have to kill the cancer, but we don't want to kill the patient along with the cancer. So how do we get through that, this initial period of treatment and all the short-term side effects, and take into consideration what the long-term consequences are? So we did have to adjust some doses. And the other part of that was, well, the first part, getting through the treatment, that's where, a lot of it was up to you. You got through that by keeping yourself healthy and paying attention to what you had to do so that the medicine would work, but not knock you out completely. And that was exercise, diet, getting enough rest, keeping that healthy lifestyle going even through those very, very tough treatments. Now that you're through all of that, and hopefully we're going to look back and say that's all behind us, what do we do going forward? So we need to be aware, the doctors do, of what the long-term consequences of this treatment can be and help you continue to have a healthy life going forward. It doesn't just end when treatment is over.
Oh yes, you have to. I'm sure you're well aware that we walk out that door and we wonder if we're waiting for the other shoe to drop.
I know.
The fear of recurrence is a very real anxiety.
It is very real, but I also know that with each day and each week and each month, women begin to accept and trust themselves and their bodies and to believe that they really will be well. Of course, there will be some recurrences, but fortunately in the United States, still most women will be cured of their breast cancer. And even if there is a recurrence, the strides we are making now in treating advanced breast cancer are enormous.
I know you don't have a crystal ball, but so many women have asked the question, how far away do you think is a cure?
Well, that's a tough question, but what we're learning about breast cancer is it's not just one disease. There are many, many different subsets of breast cancer. And as we're getting better at understanding the biology, our treatments are more targeted, and I think our cure rates are getting better. So I'm very optimistic. We've already seen a big improvement in breast cancer-related mortality over the last few decades, going down, and I think we're going to continue seeing that. So we need early detection, more research for treatment, and then follow through for long-term health afterwards.